3 is the hepatocyte nuclear factor 4 alpha. Each type of monogenic diabetes has a specific phenotype together with the diabetes. It is not that common. It's rare. It accounts only to 1 to 4% of all cases with diabetes. So we're talking about rare forms of diabetes. Still, the commonest type is type 1 and 2, type 1 more in children. I'll discuss briefly the commonest form of MODY, which is MODY3, which is caused by hepatocyte nuclear factor 1 alpha. It's often mistaken for type 1 diabetes, so a patient can be followed in the clinic, seen and diagnosed as type 1, and he's continued on insulin. What characterizes this type that they do have low threshold for glucose in the kidney, so they do have glycosuria postprandially even before they're hyperglycemic in the blood. So they do have renal glycosuria because they have defect in renal reabsorption of glucose. Usually, when they start, if you catch them early, their fasting blood sugar is normal, and they do have postprandial problem. They do have a large increment when they're put into oral glucose tolerance test, or even postprandially. It's usually more than 5 millimole. With time, their fasting blood glucose level will be impaired, and they go into symptoms of the osmotic symptoms of polyuria, polydipsia. That's why they can be mistaken easily for type 1 diabetes. Another important point which can have an impact on the management is that they are very sensitive to sulfonylurea. Even they were very poorly controlled with insulin. Their A1C was very high. Once you shift these patients to sulfonylurea, they go into hypoglycemia, and then control is very easy. They need around 1/3 of the dose of sulfonylurea of the, they need around 1/3 of the dose of the insulin when they require the insulin. However, they do have tendency for developing complication, and the complication is related to their level of control, as in type 1 and type 2. It's an autosomal dominant disease, but with a high degree of penetrance. And around 60% of the patients develop diabetes before the age of 25 years, and around 80% before the age of 35 years. The penetrance is partly determined by the location of the mutation in the gene itself, and if the mother is the carrier, or the mother is the one who transferred the gene to her child, if she's having hyperglycemia during pregnancy and the child was exposed to high sugar during in utero, then the chance that he will have or show or develop diabetes will be earlier than those who did not get it from mother, and the mother was not affected during pregnancy. The second common type of MODY is glucokinase deficiency, which is an enzyme that controls the rate-limiting enzyme that controls the excretion of insulin. So it is the enzyme responsible for the set point when the beta cell decides to produce insulin. It accounts for 25% of cases. Usually, they do have mild, persistent fasting hyperglycemia. Usually, it's between 5.5 to 8 over many years. So it's a problem of the set point of the beta cell to produce insulin. Usually, these patients are diagnosed incidentally. They don't have symptoms because their hyperglycemia is mild, and the A1C is also mildly elevated. If you do the OGTT test, they do not have that large increment of glucose postprandially. Parents might be having type 2 diabetes or might not be diabetic because they have very mild diabetes. So in these patients, you need to go and check the family, screen the family. They do have relative protection from complications, and generally they don't require treatment. They do not respond to sulfonylureas nor to insulin. So it's better to keep them without treatment. Coming to the third type of monogenic diabetes, which is type 1, is less common. It is similar to MODY3, but with certain features that discriminate between them. They do not have the low renal threshold for glucose, and it might be diagnosed later in life. Again, they require treatment and they're sensitive to sulfonylurea. 50% of cases are macrosomic at birth, and 15% do have hypoglycemia soon after birth, and it's diazoxide responsive. But they do have hypoglycemia in infancy, they come out of it, and then later in life they develop diabetes. So always ask about history of hypoglycemia soon after birth. Carriers of certain type of mutation do present with atypical form of Fanconi syndrome. So when to consider monogenic diabetes? When do we need to suspect that your patient is not having the common form of diabetes? If the diagnosis was below the age of 6 months, even if you're seeing your patient and he is 10 years, 16 years, 25 years, you go back to the history, he was diagnosed soon after birth, then you need to suspect that he has monogenic diabetes. And if there is familial diabetes with an affected parent, the parent is having diabetes similar degree. If it is mild, and if you have good control despite minimum effort and minimum dose of insulin or medications. Like patient is not doing any effort and yet his A1C is 6 or 5 or 7. And if you still have detectable C-peptide after 3 years or 5 years from diabetes, usually the honeymoon will not extend that far. And of course, if you cannot detect antibodies, and the most important time of detecting antibodies is at diagnosis. Apart from the other features that we mentioned, some types of monogenic diabetes do have certain features, certain phenotypes, like pancreatic dysfunction, or developmental delay, or renal disease, or genitourinary abnormalities. And there are certain application in the Mac and iPhone, and in November it will be in Android phones too, where you can download this program, and you can calculate the probability of your patient having a rarer form of diabetes or monogenic diabetes. It's a simple program to ask you a few questions regarding family history, C-peptide level, and all. And in that program also there is, in that application, there is also more information about the rarer forms of diabetes, and it will provide you for the calculator of C-peptide, how to calculate and how to do the conversion of conversion factors. And it will give you a lot of help and aid in diagnosing rarer forms of diabetes. It's available for free, this application, and in November it will be available for Android phones too. Now I'll be talking in this part of the lecture about our study at DASMAN, which is monogenic diabetes in the young, a study from Kuwait. The aims of the study was to detect molecular pathology of monogenic diabetes subtypes in Kuwait, to clarify phenotype and genotype relationships, and to have better understanding of the associated features, natural history of the various subtypes that are running in our population. This is the flow chart of how is the study going on. When you suspect that the patient is having a rare form of diabetes, you refer this patient to our clinic at DASMAN. It's on Wednesday. And either you do the survey, or we'll survey the patient, we'll reassess, and we can do also C-peptide antibody to put the patient and calculate his probability of having a monogenic diabetes. After fulfilling the criteria, we enroll the patient to the study, and we take blood sample. We do test for monogenic diabetes in our lab, the genetic lab at DASMAN. Dr. Osama Samadi is doing that in his lab. And we do send another sample to Exeter lab in UK, which is a very accredited lab. We're validating our results with Exeter lab. We take only 10 cc, 5 cc each, one to be studied in Kuwait and one to be boarded to UK. We've also, this slide, I've got it from Dr. Debbie from Dundee University. We've used this slide to raise the awareness about monogenic diabetes, where the patient is divided into high risk, medium risk, and low risk. It will give you a good help and aid to put your patient or suspect your patient having a rarer forms of diabetes. So we've enrolled patients who have diabetes and they had negative autoantibodies and family history of diabetes. And we were testing for monogenic diabetes genes. We've started with 3 genes, the most common genes, and then we've opened for all known genes in the lab. So after doing all this workup, after taking the patient, examining him, and taking the blood samples, sending it abroad, all these difficulties and effort, does it matter to diagnose the patient correctly as monogenic diabetes? If he's type 1, he's on insulin, or even if he's type 2, sulfonylurea, it's the control that matters. Usually you think it's the control that matters. So does it matter? Yes. While type 1 and type 2, there is no single diagnostic test. In monogenic diabetes, there is this DNA testing which can label your patient correctly with a correct diagnosis. Secondly, it can predict the clinical course of the patient, explain the other associated clinical features, and guide to the treatment. And thirdly, you can provide proper counseling for the family who is having this gene running in their generations. The most important thing is that you can change the life of a patient when you diagnose him correctly. A good example of that, though I did not speak about, is the neonatal diabetes, where having certain mutations will render the patient sensitive to sulfonylurea. These are patients who were diagnosed before the age of 6 months, means babies on milk all the time. So shifting these patients from insulin to sulfonylurea will change their life. As you can see, the control is much better on sulfonylurea than on insulin. Coming to the first case, we diagnosed this patient, Noura, as you remember, as having MODY type 3, and we've informed her doctor, so she was shifted to sulfonylurea, and her control was much better, 6.8, and she was saved from pricking herself 4 times a day. For the second child, Baddah, who had renal disease, he was labeled as having hepatocyte nuclear factor 1 beta mutation, renal cyst, and diabetes syndrome. This is the results of Baddah. And for the third case, she was labeled as Rapson-Mendenhall syndrome. And this patient, we're now considering IGF treatment. We're trying to collaborate with centers abroad to provide her with IGF-1 treatment as a trial for better control of her diabetes. Unfortunately, all these patients refuse to do further screening of the family. So what are the obstacles? We are receiving very less number of patients referred to us from either endocrinologist or polyclinic. So we're looking for more patients. We know that we have more numbers of patients suffering from monogenic diabetes. With that, I conclude. Thank you.
Thank you, Dr. Hassa. Very, very nice, easy made topic because of a very difficult, actually, disease where we actually don't think about it when you have diabetes. We're already geared toward type 1 and type 2. And as Hassa said, there is more of these cases. So in the primary care physician, in particularly in your area, that's where you actually can pick up these cases to actually refer them to the specialist. So any question? We have 2 questions, please. I can see the iPad and camera for the withdrawal is coming. So السحب في 3 سحوبات اليوم على جوائز. Every break there is سحب. This is the first one after we finish the questions. Dr. Zaidan, تفضل.
Thank you, Dr. Hassa, for this very nice presentation. I know you are doing your best for this new item of diabetes, which is a gene problem. So my question for the adult side, Dr. Walid, for example, are they looking for this patient as we are looking for this in the community? Is there any collaboration between you and the other side? So I think many of these cases, as youth and older, they should be seen by the other side.
The first patient, Noura, was referred actually from an adult endocrinologist. We tried to, by communication, by talking about monogenic diabetes in conferences, to raise the awareness among adult endocrinologists and also among primary healthcare physicians. The last slide that I've shown is actually a brochure or a flyer that was distributed to all primary healthcare centers in Kuwait. Our research assistant did a great job by distributing the flyer, which shows the risk slide, which shows whom to contact and when to suspect monogenic diabetes. But we're still looking for more cases to be referred to us.
Any feedback now from the other side, adult side? So, Dr. Walid.
Dr. Walid, it's for you. Why are you not referring
Any feedback
patients
for
to us?
this type of diabetes from your side, adult side?
I cannot answer that for myself. I mean, as I told you, I mean, we as adults, we already get the type 1s especially, who are already being seen by pediatricians, and they come to us. And most of the time, because they are filtered, so we don't see these, type of patients as most frequent as you in the pediatrics. But that doesn't mean that we have to look more for these patients. We have few that we actually suspect and then refer, but there is no, unfortunately, one group for monogenic diabetes in Kuwait, for example, where they can go all in one place, which is a very good thing. Dr. Mohammed Hassani was talking to me about a program in UK where he was also involved, where there is, monogenic diabetes unit where they can pick up cases all over the country. And that's probably something we can work together and create in Kuwait, and that's going to be a very successful thing. Yeah.
Dr. Walid, the diagnosis is very easy. They need very small dose of insulin, as Dr. Hassa said. A1C is under control, and they are non-compliant, but they are doing very well. So this is the diagnosis, Dr.
Yes,
Hassa.
but you need someone to look for it.
Okay.
Somebody with a clinic of 40 patients will not think about, these such things. But we have to raise awareness, and I'm sure. Dr. Samadi?
Thanks again, Dr. Hassan. It's a great talk. Is there knowledge or data on Kuwait, Modi, how much that represents from all types of diabetes relative to global statistics? And do you also think we may be or going to see some more rare forms of Modi in this country?
I don't think there is data in Kuwait regarding monogenic diabetes. As I mentioned, that even our physicians are not very aware of these rare types of diabetes. So we're trying to collect more cases by increasing the awareness and by maybe publishing some data from our study. Then we can go for more sort of incident reports. We do have the registry of diabetes, which is detecting type 1, type 2, and other forms. But if the doctor himself did not diagnose this patient correctly as monogenic diabetes, then he will not register him as monogenic diabetes. What we see is that certain doctors have labeled the patient as the type of diabetes is unknown, as me and Dr. Azza were looking into the results of the registry. So this is of course, for pediatric. For the adult, it's even more difficult because, as Dr. Walid mentioned, they do take the diagnosis for granted, as these patients were diagnosed by the pediatrician, and it's type 1 diabetes. And as I've mentioned, that when we started our practice, we presumed that all our patients are diabetic. Even in certain centers, antibodies, C-peptides are not done at diagnosis because it's 90% type 1 diabetes, so start insulin. Why to bother to look for a C-peptide or for antibodies? And as mentioned before, it's the antibodies at diagnosis is very important. It's not the antibodies that you do later on, because it can be negative later on. We hope with more awareness that we receive more patients, inshallah. Thank you.
Thank you, Dr. Hassan. Now, you're
There will be another withdrawal before the session, the next session after the lunchtime, okay? So come here after finishing the lunchtime, there will be another withdrawal. إذا مو موجود اسحب غيره. إذا مو موجود اسحب غيره. Okay. Yeah, one more.
كمال موجود؟
تفضل يا دكتور.
تفضلي دكتورة تفضلي. لا بعد مش موجود. جاي؟ يلا كمال تفضل. راح يكون في سحب ثاني بعد الغداء ان شاء الله.
في ايباد ثاني يعني خلينا.
في ايباد ثاني بعد الغداء. خذي هذا. مبروك. يقول اول مره بعد عمر ال50 فاز بشيء بعمره. We'll start our next session. قبل لا نبدي راح نسوي سحب مرة ثانية. تمام؟ ففي سحب الحين وفي سحب آخر اليوم وفي سحب بكرة الساعة 8 الصبح. أوكي؟ عشان تيون. فراح نبدي السحب الحين then we'll start our program. تخيلوا إن ساحبة اسم زوجها. نعطيها الهدية ولا لا؟ يس كم يلا. خذيه. It's okay, take it, go. الحظ ما إلا مرة واحدة بالله. بعد عندنا واحد ولا بس واحد؟ One more. دكتور أحمد السهلي الساحلي. أحمد. يلا بعد واحد. لا مضيوف كله. دكتور شجاع الدين. يا تو قاعد يقول ما حد اعلم في الصباح. يلا now we get something. هلا والله خذ هذا مني. Thank you. Thank you. Thank you. So nice of you. Oh, that's good. Okay, good. Okay. We'll start our program. Our next speaker, Dr. Mohammed Hassanein. Dr. Mohammed Hassanein, he's also a friend and a colleague. Mohammed Hassanein, he's one of the icons in diabetes in the area. He was a professor of medicine endocrine in Cardiff University and in Northern Wales University. We are lucky to have him to move to our area, to Dubai recently. So he's joining Dubai Medical Center recently. Dr. Mohammed have lots of publications. He devoted his career to diabetes, and mainly if you talk about diabetes and Ramadan, you get the best guy to talk about this. He's going to talk to us today about hypoglycemia and diabetes. Dr. Mohammed Hassanein, thank you for joining us from Dubai.
Thank you very much, Dr. Walid. It's a great pleasure to be here, and thanks for your kind introduction. It's good always to come to Kuwait with lots of friends and to be in this lovely country. It's just after lunch, and it's always difficult to get people going after lunch with postprandial hypoglycemic effect. So now we'll talk about something different, which is hypoglycemia from a cardiovascular perspective. Now, we all know that diabetes is associated with potential loss of life. It is estimated that if I'm 50 years old and I have diabetes with no previous history of vascular disease, I might lose 6 years of my life. Can you hear me at the back of the mic on? Can you hear me at the back now? Okay. Okay. So what we're saying is really, it's the data is telling us that if a person of 50 years old with type 2 diabetes with no previous history of vascular disease could potentially be losing 6 years of his life or her life unless we start doing something. When I personally looked into the data of my previous hospital from 2002, maybe because of the referral system, the vast majority of our patients have poor control because of the being referred to us with complications, or 40%, 47% of them have already macrovascular disease. I had to remove one slide because of the incompatibility. We just recently had one paper about cardiovascular disease in Arab countries with the collaboration of many colleagues from the Arab countries, and the cardiovascular conditions are in abundance in the Arab countries. Smoking, hypertension, obesity, diabetes are not so accurate. So I suppose the vast majority of us would like to believe that intensive glycemic control is associated with cardiovascular benefit. That's what we would like to feel is what we're trying to offer our patients. The reality is slightly different. The reality of meta-analysis, and I personally do not like many meta-analysis because of confounding factors. But if you were to look into meta-analysis, do we have evidence that intensive glycemic control would improve cardiovascular outcomes? And the answer from the meta-analysis of these 4 mega studies, UKPDS, ADVANCE, ACCORD, and VEDT, is no. So let's look into the actual data and try to analyze, is it really no, or is it something wrong with the meta-analysis? So if you look into the 3 mega initial trials, the first UKPDS looking into metformin effect, and the UKPDS looking into sulfonylurea and insulin, as well as ADVANCE and the Veterans Affairs trials. If you look into them, you will find only one of them have outcome, which is the metformin data for cardio or macrovascular outcomes, cardiovascular events. However, later, the UKPDS confirmed that even the sulfonylurea and insulin, as well as metformin, do have indeed data for cardiovascular outcome. But ADVANCE and VEDT did not. ACCORD trial, which was a trial trying to look into a large number of patients to get the glycemic control as normal as possible, thinking that if we normalize the glycemia, then you're actually reducing or eliminating a big portion of the risk. And the outcome, unfortunately, was the trial was terminated early because of increased mortality, even though they have managed to get the glycemic control pretty good. So it's kind of a bit confusing. One day you hear glycemic control